morning, guys, and happy Saturdays. We're going to get started with the endocrine system today, and I'll get a quick snapshot of the key objectives. So we'll start with some of the major glands and just outlining what's involved so that everybody has the same level of understanding. We'll go over structure, function, and then we'll talk a little bit about histology. I have a couple images that highlight specific glands and their cell types. We'll go over hormonal regulation. We'll talk about metabolism. We'll talk about how it impacts the growth, reproduction, homeostasis. We'll also talk about the interplay between the glands and other systems. Hormones work in a tier system. Every time I teach the endocrine system, whether it be just one topic or a general, the entire system, think of a tier system. There's tier 1, tier 2, and tier 3. And then it goes from the top, right, hypothalamus, pituitary, then the gland. So tier 1, tier 2, tier 3. We'll talk about the synthesis, storage of some of the hormones, like the thyroid. We'll talk a little bit about the specific targets, and I'll have a couple of charts in the PowerPoint deck that puts it all together. So as you're studying and trying to remember the functions of each of these hormones, it's quick and it's a snapshot. And then we'll talk a little about diseases towards the end. I will have a virtual cadaver, so it's the one on the APR. It's really good. This one's good because it shows you the glands, and we zoom into it. All right, so first and foremost is just a snapshot, right? The whole body contains several glands from head to toe, and these glands are unique in the sense that they create specific types of compounds, whether it be a peptide or steroidal-based hormones. Hormones are classified based on either water-based, so water-soluble, or lipid-soluble. Lipid-solubles are your ones with the ON, right? Aldosterone, testosterone. I think the battery is. Give me a second. Let's pause it. There's a lot of glands from head to toe in the body, and these glands have the ability to create specific compounds that are hormones. They're either lipid-based or water-soluble. And these glands are controlled in a tier-based system. Tier system meaning that the first tier, the highest level, will be your hypothalamus. Your second tier, the middle tier, will be your pituitary. And then the final tier, which is what actually releases the activated tropic hormone, is the gland. So there's going to be a releasing hormone between hypothalamus to pituitary. And then there's going to be a stimulating hormone from the pituitary to the gland. And then the gland gets to say, okay, all right, we need this signal, so it's going to produce that hormone. In all cases, the regulation follows the negative feedback. Negative feedback means that when you have a lot of that tier 3 hormone made, then you can subtly reduce the input to reduce tier 1, tier 2. Okay, so just to give you an example, TRH, thyroid releasing hormone, stimulates TSH, thyroid stimulating hormone, which will then activate the thyroglobulins to inactivate T3, T4. Thyroxine and triiodothyronine. And these hormones have the capacity to then regulate your bone density, your muscle activity, your bone growth. And then ultimately, when there's enough T3, T4, it's going to naturally shut down your TRH, TSH. When you're diagnosing issues and whenever there are endocrine problems, you always need to think about that negative feedback. So in a case where somebody that has hyperthyroid, and we'll do a case study to kind of get that snapshot clear, but the hyperthyroidism, what happens is what? Which one will be elevated? If you were to have hyperthyroidism, that means T3, T4 are high, right? The final hormones have to be high. They're going crazy. And in cases where there's a tumor, that means the negative feedback is not working. So when that happens, that means either the T2 region, your pituitary, or your hypothalamus, T1, have some kind of tumor that is still pumping out that hormone that can then activate the tier 3. Okay, so just a quick snapshot. From head to toe, pituitary gland, there's the tropic hormones, the anterior pituitary. A mnemonic that you should know is called flat pig. I use this all the time, flat pig. So pig is flat. FSH for the first letter F. Second letter L is LH, luteinizing hormone. And then A is ACTH, T is TSH, P is prolactin, and G is growth hormone. The I is just nothing. It's like lowercase I for nothing in there. And then that corresponds to all of these anterior pituitary hormones. The only two that are generated by the posterior pituitary will be your oxytocin and ADH. Oftentimes, there's several names that refer to the same hormone. Okay, when you're using an older book, the ADH might be referred to as argypressin. Maybe you have a different text or different class. They call it argypressin, vasopressin. And then the LH, this one right here, luteinizing hormone, also has an old school name called ICSH. So if you're reading an older book, some books refer to it ICSH, interstitial cell stimulating hormone. That's an older term that they use to refer to as LH. Okay, so if you ever see LH, ICSH, same thing. And then out of the endocrine glands or the trophic glands, you're going to have some that are located on like the posterior thyroid. We have the parathyroid. We have the adrenal system. We'll talk about the different layers. We went over the pancreas, so we're not going to go over insulin glucagon in this topic because we've spent some time on that already. And then the GI system as well. Okay, so a quick snapshot of the overview. So we'll begin with a quick couple of lines about hormones. Is that number one, these are chemical messengers that are dedicated to a specific target site. They flood around the course of your bloodstream, so they have to be transported either through some kind of globulin protein, albumin, or binding globulin that can get from A to B. And once they make it to the target, they bind to a dedicated receptor. The difference between steroidal-based hormones and water-based hormones is very simple. Steroidal-based, anytime you have a steroid, they can penetrate the cell membrane and directly activate the genetic transcription of the cell. They bind to some sort of a nuclear element. Okay, so just remember that steroid hormones are steroids. So steroid hormones meaning cholesterol derivatives. So let me just give you a list of them: pregnenolone, DHEA, testosterone, estrogen, cortisol. Any of these ons or alls are all going to be steroid based. Okay, you don't need to know all the names now. Just know that they're steroid. And whenever I say steroid, that means they bind onto the nuclear receptor. They go through the cell and they directly affect transcription, translation. Then the counterpart will be either amine-based or peptide-based. Okay, so the other group will be amine. These are the protein-based or peptide-based. And these hormones will generally fall into the category of they typically bind G proteins. Okay, so GPCR. So they're going to bind some sort of extracellular receptor that is integral to the membrane, and that will then activate the second messenger and then effector enzyme and then a series of cascades. All right, so steroid versus a peptide. One example, out of all the hormones that we have today, the only one that is unusual will be your T3, T4, triiodothyronine and tetraiodothyronine. Number of iodines are different, but it's just thyroid hormone. This one, even though it is considered a peptide-based hormone under the left category, it behaves like a steroid. It binds to a heterodimeric unit inside the cell, and it directly activates with a co-receptor. This is called the retonic acid. Did you guys get a chance to talk a little bit about this one? So it's a vitamin C derivative, the retonic acid. So there's two different compounds that bind together, but it links directly to the cell's gene. So when thyroid hormone is activated, it actually, one of the functions is it directly affects the receptors of all the other hormones. So you might think, okay, thyroid is just weight loss and metabolism. Yes, but it can indirectly affect the ability for other hormones to respond. So thyroid health is pretty important. Just maintaining the adequate amounts of iodine or even not taking too much iodine can be important, because if you have too much of it, you have a goiter. Too little of it, you have a goiter. Okay, being hypothyroidic, goiter, if you're hypertoxic or you have toxicosis or this onset of this flood and attack, you also have an extreme amount of chance of getting goiters. Okay, and we'll go into starting first. So the first part of the story begins with your tier 1. The tier 1 is all inside the hypothalamus, and the hypothalamus is going to be where all the signals originate. This is where you have the releasing hormones. There's a set of nuclei that will then send a signal to the pituitary gland. The hypothalamus is divided into subnuclei like the supraoptic, the preoptic, and then these regions have small neurons that will then release chemicals. So when you think about the first tier, they're really more of a neuron-based system. There's this infibitulum, the stalk between the hypothalamus to the pituitary. You can see a small little region. There's a plexus called the HPA axis. This is the hypothalamal hypophyseal portal axis. It's a small network of capillaries that allow the hypothalamus to quickly signal down to the pituitary. The signal is very, very quick in the sense that once your hypothalamus gets the stimuli and your body responds, it can quickly go down. Then we have the AMPIT, the anterior pituitary, and then it's divided basically by the stalk. This little stalk region contains most of the melanocyte-based receptors. And then in the front, we have the nervosa and then this distalis. Okay, so some books might use the term nervosa, and then some use the distalis, but this is the AMPIT, postpit. The two hormones from the back are the oxytocin, ADH. Oxytocin is so you have the anterior distalis, and then you have the posterior nervosa.
Wait, I thought anterior was nervosa.
Yeah, so nervosa is anterior, so adenohypophysis, that's the front part, and posterior hypophysis is the distalis. So distalis is the back part. Distalis, yes, distalis, and then is my mic going off? We'll hope. And then the nervosa. Yeah, and then it's also referred to as adenohypophysis. So adenohypophysis on the front, and then the posterior. Okay, all right. I don't know. I'll just. Are you guys okay without the mic? Because it keeps cutting off. Okay. Just came back on. Okay, all right. We'll just keep going. And then over here, just highlighting some of the key features of the HPA axis. Number one, this is a plexus that links the hypothalamus to the pituitary gland via a set of small portal veins and portal axes. And then within it, in the anterior pituitary, we have the smaller secondary axis that has all the capillaries. So it's a quick way to flood the gates of the signals down. And then in the anterior, we have these smaller hypophyseal veins that are important because they allow the activation of those trigger cells, those gonadotropic or different cells that will then activate the tropic hormones. Tropic means it grows. All of those ant-based hormones or the flat pig hormones are tropic in nature, meaning they activate the size and the growth of the gland. If there's an abundance of any of the flat pig hormones, so FSH, LH, ACTH, TSH, prolactin, or growth hormone, it's going to grow the cell. The cell gets larger and gets thicker. And their dedicated specific function oftentimes depends on the target, so wherever it goes to, it binds. There are applications where if a patient has some sort of a dysregulation or a disconnection between the hypothalamus and the pituitary, then there could be issues with hormonal communication. Most of the time, whenever there's a primary disease, when they say primary case of a hormonal issue, that means it's the gland itself. Okay, whenever it's secondary, then you have to go into the brain. And so the big dilemma here is that if you were to have a tumor in the brain, you don't ever want to make the wrong decision on which part to excite. Pure hypophyseal artery on top, and then the hypophyseal portal vein, shown in blue, just the network. You can see that there's a small little stalk region, the infibitulum, that little midsection where it joins together. And then the secondary plexus is going to be within the AMPIT. So right here, this is secondary plexus. Right on the back here, we have the posterior pituitary. It's always interesting when you see this in real, right? The staining, depending on how the histology image is presented, you can kind of see the infibitulum and then the size difference between the AMPIT and the postpit. In this picture, it's not really that distinguishing, but the bottom part over here that then releases to tier 3 are going to be your inferior hypophyseal. So superior, and then secondary plexus, inferior. Okay. Anterior, posterior. The mid region is your stalk. The infibitulum is the junction between the hypothalamus to the pituitary. And in cases where there are diseases here, oftentimes when they do like an MRI or they scan it, they'll realize there's enlargement. So enlargement of the sella turcica or some sort of a irregular activity in this region. And that's one way you could say, okay, well, maybe if the hormones are increased in the gland, so the thyroid gland is healthy, your adrenal gland is healthy, maybe the problem is in the brain. And that's when you will, have to either make a decision. Usually if it's a tumor, you got to excise it. And which region are you operating on, or what are you going to be targeting? All right, so over here, this is the list of the key tropic hormones, and I have it highlighted. These ones are your tier 2. So we have the TSH, FSH. Thanks, Louis. Oh my gosh, that was really bad. Okay, cool. All right, so let's backtrack real quick. So over here, the AMP pit secretes those key tropic hormones. And then we have the AMP pit, so the flat pig hormones that I just mentioned, the TSH, FSH, LH, ACTH. These are tier 2, by the way. Sorry about that. So tier 2. And then the growth hormone, which will then in turn activate IGF-1, which are the functional. And then the one that we don't talk about, that oftentimes gets omitted, is its ability to secrete MSH. So melanocyte stimulating hormone generated by that intermediate, that section that it divides the AMP pit to the post pit, does regulate sexual development. So in some studies, they've discovered that for male maturity and puberty, not only does it play a role for the coloration of the early on melanin production in the body, but also sexual development. So the maturation of the male gonads and female gonads is also directly linked to this hormone. They don't know the full interaction and interplay of how this works, but early embryonic development, it does play a role for the maturation phase. And then for the growth hormone, the key activation is the targeting for the liver's IGF. So IGF is what functions to trigger the growth and then the activation of all the muscle density and growth. All right, so let's keep going. So over here, a picture showing you the visual. So all of the releasing hormones on top. We have TRH, that is going to stimulate TSH, which will then in turn activate T3, T4. PRH is prolactin releasing hormone. Most of these hormones are either going to be turned off by the environmental and your body's stimuli, or there's a direct counter hormone. Some hormones are antagonistic, meaning that there's another hormone that can directly inhibit it. In the prolactin series, dopamine naturally is the inhibitor, and when the inhibitor is removed, then the hormone is activated. Then we have the GnRH, gonadotropin releasing hormone. This one will then target up the activation of FSH and LH, both together. It's going to be non-discriminate. One of the recent studies about how GnRH is regulated is interesting, because when you think about the cycles of the females, or if you think about libido and puberty, there is a neuropeptide that can interplay to trigger the activation of GnRH. And that newer compound is called kisspeptin. Anybody heard of this one? It's the kissing signal. So it's called kisspeptin. So when you are engaged in romance, it suppresses opioids and GABA signals in the brain. So GABA is an inhibiting based, suppressing based, IPSP based signal in the brain, neurotransmitter. And that will then activate the neurons, which will trigger another modulating peptide called kisspeptin. It's referred to as a kissing signal. And that will then activate GnRH. It makes sense. So kissing or hugging is naturally one of the most non-invasive ways to activate these hormones. So when you're feeling pretty good and you're in love and you're in that, I guess, the infatuation stage of romance, that kind of naturally is going to be higher. And then we have the CRH, which we'll talk about as well. That will then activate ACTH. These are all tier 1, by the way. So these releasing hormones are all tier 1. And that will then activate the ACTH to the whole cortisol pathway. That's a whole chain. The cholesterol pathway, which is what we call steroidogenesis, is complex. So what happens is you have cholesterol on one side, and on one leg of this pathway, you create the aldosterone. In the middle leg, you can make cortisol. And on the far right leg, you make sex hormones. So testosterone, estrogen, estradiol, estrone, those are one reaction apart. But the common shared pathway is going to cholesterol. Cholesterol goes to pregnenolone, that's an intermediate, and then becomes 17-alpha pregnenolone, and then becomes another chain down the road, DHEA, androstenedione, and then it goes down the chain. So there's a common pathway before it diverts and then branches out. And then we have the growth hormone, releasing hormone. This is the one that stimulates growth hormone. The name just tells it, right? So GHRH goes to growth hormone. We have 2 inhibiting hormones that I want to highlight. PIH, dopamine, and then also the GHIH, growth hormone inhibiting hormone. That's the somatostatin, the one in the GI system. Over here is a visual to show you where they target and what they do in simulation, and you should be mindful of the function. Okay, so the 2 hormones will begin is going to be the ones made by the post-pit. So the question I have for everybody is, do you really call these chemicals hormones if they're generated by neurons? Well, when you kind of classify the term endocrine or hormones, usually that means it goes through the blood. It's dedicated by one dedicated glandular cell and has a target. So there's a little bit of overlap, but over here's a picture showing you the 2 cells, the paraventricular nucleus inside the hypothalamus in the supraoptic. The paraventricular is what releases oxytocin. And oxytocin plays a role to do what? Birth. Okay, good. So in the female system, it's a positive feedback that increases the uterine contractions through muscle. What else? What else does the oxytocin do? How does it do for the males? What's the role that oxytocin plays for the males? It's usually, it gets elevated during climax, so ejaculation, but it's not nearly as direct of a role. Okay, but it does kind of regulate a little bit part of the ejaculation, but it's more dominant, especially in the females, for labor. And then the supraoptic nuclei, shown here in yellow, so it's just indicating that there are two sets of neurons. If you look at the histology or when you do the biopsy slide, you can't tell the difference. These cells are all like clustered so densely, but they are different. So there are a different set of neurons that can release the different compounds. Supraoptic makes ADH, antidiuretic hormone. And what's the function of ADH? Anybody? Antidiuretic. So if it's a diuretic and it's anti of a diuretic, what does it do? Right. So you're not trying to lose water, you're trying to reabsorb water, right? So the key here is that it's going to then help you increase the water channels, the aquaporins inside the ductal cells of the nephron, so collecting ducts and DCT, and that will then encourage more water flow back up. And then over here, you can see again that hypophyseal portal system, that small little region of the stalk intobidulum. And then that comes down and it directly releases through the pars nervosa. So over here, there's this gland cells region, thin region, they release out. What's interesting, guys, is look at this. So it's made by the hypothalamus. There is no tier 2, and it goes directly out. So this is the posterior pituitary. These two hormones, oxytocin, ADH, they're just tier 1 all the way to the body. There is no issue. So if there is a dysregulation of oxytocin, ADH, where is the problem? It's always in the brain. So whenever you have a patient where there's a dysregulation of ADH, so diabetes insipidus, right? And let me just give you the example here. So there's several classes of diabetes. There's type 2, right? Diabetes mellitus, where there's insulin dependent. And there's another one called insulin independent. The third class of diabetes is called diabetes insipidus. That's when there's a dysregulation of ADH. And that means the person is drinking a lot of water, right? And then what happens, you think you're hydrated because you're urinating and your urine is very clear. But what's happening is that the receptors are not allowing the water to be reabsorbed. So what's going in is coming right out. And in those cases, it's the brain. Okay, so it's an easy pinpoint in terms of where the issue is located. All right, so let's start with a nice little chart. So this is good. So as you're going over the hormones, I list out 3 key items: the source of the cell type that releases it, and then we have the target, where they go to, where the key receptors are located, and a very, very brief key effect. Okay, so you can go into each of them more detail. As a matter of fact, next year when you're in the medicals program for the endocrine course, which is usually in the first class, second class, sorry, after the year, so it's about January, February. Each session is dedicated to one hormone. So you're going to look into all the stuff in the thyroid hormone, all the stuff in the progesterone, all the stuff in the prolactin, all the stuff inside each of them. But here's a quick snapshot. So ACTH, adrenocorticotropic hormone, ACTH for short, is generated by the corticotropic cells inside the pars totalis. The main target here is going to be the adrenal cortex, the outer layer. I have another mnemonic, or just 6 letters that match over there. Now I'll fill it out, but the next mnemonic here is your GFR MGS. Okay, and this will make some sense in a second, but GFR stands for glomerulosa, fasciculata, and the reticularis. That's the 3 zones of the outer cortex of your adrenal gland. The inner gland are going to be all medulla and chromatin cells. So that when you think about adrenaline, that's all medulla. GFR is strictly the cortex. And then the MGS that matches with each of the letters, the M goes with the G, the G goes with the F, and the S goes with the R, means mineral corticoid-based hormones. And then we have the glucocorticoids, basically cortisol, GCs. And then the last one are sex hormones, or androgens. So androgens meaning you have androstenedione, that's the precursor to testosterone. That it becomes testosterone, and there's one aromatase enzyme that converts testosterone over to estrogen. Okay, and I'll show you all this in a second, but just there's a lot of interactions here. The second hormone that we have here is FSH, follicle stimulating hormone. The way that I always like to tell you, in case you don't remember endocrine or this is your first time being exposed to it, is FSH literally is the word fish without the letter I. And a fish looks like this, and a fish looks kind of like a sperm. And so this FSH is one that stimulates the sex cell. Sex cell as in the male spermatogenesis, going from the early spermatid to maturing. And then for the females, it's what? What's the sex cell for the females? Right, so you're going to have the primordial follicle. The follicle eventually becomes a primary follicle, matures to a secondary follicle, and then ruptures into the egg, okay, the ovum. So it's the follicle development to the egg. All right, so that's the sex cell. And then the LH, luteinizing hormone, also referred to, I'll just make sure you're aware, is called ICSH, interstitial cell stimulating hormone. And then they target some of the Leydig cells. So in the males, Leydig cells. In the female, you have the granulosa and theca cells. Over here, guys, let me just add a little detail. So for the ovaries, okay, the female ovaries, the target is the Leydig cells. Oh, oops, sorry, that's the male. This is the theca cells, THECA, theca cells, and the granulosa. They both have receptors. Okay, granulosa, and then for the males, it's your Leydig cells. So there are a slight difference. For the male, it's one specific cell type. For females, there's two. And then the function will be different because their goal is to mature the sex hormone. So for the females, what's crowned the sex hormone? What's the hormone of the female body? Estrogen. And there's three versions, okay, three versions of estrogen. There's estrol, estradiol, that's the active form, beta estradiol, and estrone. Okay, the other two are they call it E1, E2, E3. And those other two, estrone and estriol, those are really weak. They don't really have potencies in the body, but they are found inside the system. The only potent version is estradiol. That's the main when they refer to the estrogen. And then for the males, Leydig cells are going to be the ones that mature testosterone. There's another version of testosterone called DHT, dihydrotestosterone. Okay, and that's one reaction. There's the 5-alpha reductase. That hormone is about 4 to 5 times more potent for binding to the receptors. So it has a lot more androgenic function. It's a lot more potency. But just remember testosterone and also its older brother or bigger brother, DHT. It's the kind of synergistic effects. Over here, just highlighting the key function for female. And I'll dedicate a whole slide to this, so don't worry if you're we're just going through the very quick snapshots. The ability for the female Leydig cells, the female theca cells, granulosa cells to activate is going to trigger not only the development through the corpus luteum, so after the end of the cycle occurs, after you ovulate, and let's say the hormones start to kind of drop down and lower in amount, and there is no opportunity for embryonic latching and there is no sperm, then the cycle resets. During the resetting cycle, that's where the female's hormones are going to crash down a little bit. Estrogen goes downwards, progesterone goes downwards, and FSH begins to rise. And the interplay is interesting because now you're getting ready for the uterus to develop and the progesterone takes over. So progesterone's role is more on the later half of the female's 28-day cycle, whereas estrogen's role is a little bit more dominant in the first half. So one thing to remember about the hormones, even though estrogen and progesterone, they work on the same team, is that estrogen is higher in the 7 to 14 days in the beginning of the month. And then the second half of the month, the next 7 to 14 days, is going to be progesterone taking over. All right. And then for the males, the primary function is androgenesis. So that's just a steroidogenesis going from steroid, cholesterol, pregnenolone, 17-hydroxypregnenolone, progesterone, DHEA, androstenedione, testosterone. The next hormone that we have is called the thyrotropin. This one is TSH, and TSH is going to be secreted by the thyrotropic cells, also in the pars thalamus. The main hormone is the thyroid gland itself. And then within the thyroid gland, there are these colloids, okay, these little bubble-like, adipose-like kind of fluid-filled compartments. And those compartments are what allows you to transport the peroxidase and move in the iodine. When the iodine gets transported in, there's a protein called TBG. TBG is a binding globulin that helps assemble the thyroid hormone. and that will then activate. Eventually, after it matures and your body needs the hormone, it will then release the T3T4 out. The way the T3T4 gets manipulated is strictly based on the number of iodine. So I'll show you a picture to kind of illustrate that. But there are a couple versions of the non-activated thyroid hormone, like MIT, monoiodotyrosine. That's a non-activated form. There's also a DIT, a diiodotyrosine, and it's basically the two requirements: tyrosine amino acid and iodine. As long as you have those and you have a healthy thyroid gland, you can combine them together. There is a hormone that is there's an enzyme that is a limiting step called TPO. That's a thyroid peroxidase. That's really how quickly your body can assemble it together. So whenever there's a defect in that enzyme, then there's an inability for you to make the right amount of the hormone, and that's why nowadays it's one of those more of a developing country disease. A lot of times, certain kinds of chemicals and foods might impact the thyroid gland and affect that enzyme activity. As a matter of fact, the sex hormones can also indirectly affect the binding globulin, which is really fascinating. So if you were on birth control, or if you're taking hormonal therapy, that will indirectly affect your thyroid globulin protein, which will then affect the amount of T3T4. So in many cases, when you go to your doctor, or if you're going to a hormonal workup, if you go to your gynecologist, or if you're trying to work on optimizing fertility, anything along those natures, the thyroid hormone and your sex hormone, they play really closely together. Okay, there's always a link. So if your sex hormones are off sync, maybe your thyroid hormone is off sync, or vice versa. And then the second one is the PRL, prolactin. The main function is that it's also going to be mammotropic cells inside the mammary glands. Their main function is there's many receptors throughout the female body, but for the female part, it's mostly inside the mammary glands for lactation. For the males, it's mainly for the interstitial cell, very minor. So that's why you have the sexual climax I talked about earlier during ejaculation. It plays a minor role. The milk letdown reflex, and then for the males, it plays a role for sensitivity for LH. So this does help with the ability for LH to trigger the production of more androgens. And so there's not like a zero demand. So you need to have the right amount of oxytocin, the right amount of sensitivity for the androgens to activate. And then the last one on this chart is the growth hormone, GH. And growth hormone are going to be made by the somatotropic cells. Basically, almost every body, every muscle, every bone will have a receptor that can trigger by the growth hormone. That's through the IGF. Your liver, your heart also gets enlarged as well. And then the overall function is that it just increases for the bones the epiphyseal growth plate, so it pushes the cells, and oftentimes it's prescribed if you're having some sort of a delayed development in puberty, or maybe you're stunted growth, or maybe you are malnutritioned. That's one way to heal. And also for burn victims. So when you're going through a very bad burn, you got to encourage the muscle recovery or skin recovery. Growth hormone might be beneficial to take. All right, so over here, the last two we went over already. We have just a chart. The vasopressin ADH, the key one is that it's created by both of these are directly from the neurons. So these are all tier 1. I want to make this very clear. These are all tier 1 hormones. So there are no tier 2 or tier 3 made by the supraoptic or ventricular cells. We went over this. ADH targets your kidneys, the ductal cells to increase the water uptake. For the females, oxytocin targets your uterus and mammary glands. For the male counterpart, it's mostly in the smooth muscle of the penis. And then on the bottom, I just highlighted the key function. Okay, so for ADH, stimulating of the vasoconstriction so that you don't lose any more blood volume, you're not losing any more blood through whatever means or any fluid, and then increases blood pressure by constricting it down. For the oxytocin, contraction of the uterine wall, positive feedback, so during labor, pushing the baby out. And for the males, is for ejaculation. Okay, so for the contraction of the smooth muscle to get the semen and then the All right, so over here, starting with the thyroid gland, we'll start off with some of the key regions that it's generated from. So the TRH begins its story in the hypothalamus. Through it gets released through the HPA axis, goes down to your tier 2 inside the pituitary, and then this is where you have the pars nervosa and the infibulous stalk. These cells are considered neurosecretory, so there's a mixture. And then we've said already before that right here, this is going to be the supraoptic and periventricular nucleus. Okay, so those are the two regions. In the post pit, actually, you know what? I think the title was off a little bit. Sorry about that. I think yeah. So I should have swapped this around. So let me show you a picture first, and we'll come back. So this is a picture of the thyroid gland. So we'll start with this gland first, just looking at some of the anatomy. So for the cartilages that we went over, you have the thyroid cartilage, right below the cricoid cartilage, and the trachea. And about a centimeter or two right below that, you have the thyroid gland. It's a butterfly gland that has two, in healthy cases, is symmetrical. Oftentimes you can palpate your neck just to be able to assess whether or not there's asymmetry or potential nodules or nodes. And one of the issues that oftentimes arises is when you have any growth. So there's irregular bulging growth. That means potentially indicative of some kind of a tumor or a nodule that's non-benign. But over here we have a couple of blood vessels. So we have the superior thyroid artery on top. We have the superior thyroid vein, small little vein that comes in. And then we also have the common carotid. This is the main supply, so branches out to the superior and the inferior. And then over here we have a dissecting region called isthmus. This is the middle region where it joins and wraps around the trachea. Usually nodules don't arise over here. Nodules most of the time arise on the lateral side because more blood flow is available. And they're also more prominent. So you can see it wraps around the lateral sides. And on the posterior side, you have then the parathyroid. So on the right here, this is the exact view of the cadaver. Again, a little bit of less symmetric. You can see the butterfly-like gland on two sides. You can see it on the right side for the cadaver. It's a little bit smaller, so slight atrophy occurring. And then on the left, you can see it's a little bit more prominent. And then on the back side, you'll see the four parathyroid glands. When you do a biopsy and you zoom into the cell type, what you'll notice is that it's very unique looking. Okay, these are called the colloid cells, the follicles of the thyroid gland. So what you're looking at first is you're looking at these big gel-like compartments that contain a ton of the TBG and that globulin-based iodine storage counterpart. And these are storages. So when your body needs it, it can activate it. In between them, you have the C cells and the parafollicular cells. Okay, so C cells, which you can't really see that well here, there's smaller ones that are not labeled. The C cells are what secrete calcitonin. Anybody remember what calcitonin does? So the thyroid gland does all this T3, T4, but it also contains C cells for making calcitonin. For your bone, exactly right. So that's the counter hormone is parathyroid. So one of those hormones, which we'll talk about, triggers the osteoclastic activity to get the bone cells to break down and dissolute, thereby going through the bone remodeling process. So you break the bone down, osteoclasts activate, then the osteocytes replenish, and the bone cells grow. Okay, so it's a balance between how much bone density you have. And this is also why, as you might have heard of, one scenario is, let's say, a menopause case. You go through menopause, you're 45 years old, and the hormones begin to stop. And because estrogen dips down, and I said earlier that thyroid plays a role to affect the receptors of other cells, your thyroid gland begins to decrease as well. And then your calcitonin is also reduced. So you have this chain effect where all of a sudden your body's bone density regulation is now slowed. And then you might have this one hormone that increases by a little bit, and there's a disproportionate balance of the hormones. So you have such a quick breakdown of the bone density that you cannot recover, then you're more likely to get osteoporosis. So this is also why in menopause females, there's always a greater chance of menopause. You're losing bone density a lot faster than you can recover. And then over here, showing you some of the other cells, we have the parafollicular cells shown here. This is the one in blue. They're in between the follicle. They're sandwiched between the big globules. And the big round circle are the thyroid follicles. Okay, these are called the colloids. The colloids are a mixture of the protein and iodine. What's actually really fascinating about these colloids is how your body transports iodine. So there's a protein called pendrin. Pendrin is what shuttles in the iodine in, and then as it combines with tyrosine, it will then package it together. So when you have one of the MIT, which is monoiodotyrosine, MIT, plus a DIT, right, 1 plus 2, you have 3. That's going to be the T3. Then you have the 2 DIT, you make T4. And then the half-life is different, but they're both available when needed. One of the impacts that you have is when you have an abundance of estrogen or testosterone, that will then indirectly affect your TPG, which will then affect the amount of free hormones you have. So imagine this. If you have a lot of TBG, the binding globulin for the TP54, what happens to the free version? So if you're doing a blood test, right, you go and get a blood test done, you measure usually free versions of the hormone, what's available in the blood, and also what's bound. Okay, so if more of it's bound, that means in the patient's blood work, they should have less free. Okay, so that's a very important concept. Same thing for testosterone, estrogen. There's a sex binding globulin, so SBG. And that SBG will then determine how much free version you have. So let's say you're 50 years old, and I want to see how much testosterone I have, right? Nowadays, you hear that a lot about these testosterone placing clinics and wellness clinics, and you might have, underperforming amount of testosterone, maybe 300 levels, and the range between 300 to 800 on the lower spectrum. Maybe you have a higher amount of SBG. So what's causing the SBG to not release it? Or maybe you have a decay of SBG. That means your liver has a problem. It might not be just the testes. And so there's a lot of interplay for the transporting of those hormones and how much free hormones you have. Okay, so let's keep going. Over here, summarizing what I said before for the thyroid hormone is that they contain these thyroid follicles. The follicles contain this gel-like substance called the colloid. This is a gel fluid context that has a lot of the iodine. And then the protein that binds the T3T4 is called TPG, thyroglobulin. This is what's made actively by the follicular cells. The TPG is then able to then, when needed, release it to convert it into thyroid hormone, and the T3T4 is then activated for function. What's important about this is that the follicles have these more of a cuboidal shell when they're healthy, and oftentimes in patients that have a goiter or maybe have hyperthyroidism. And the condition of hyperthyroidism is called Graves. Okay, Graves is where there's a condition of over T3T4, and then the symptom starts to become where you're extremely metabolic, you're losing a lot of weight really fast, you start to fall off hair, you're very jittery, you get something called exophthalmos, where the eyes begin to bulge out, exactly. And then the counterpart to that is the hypothyroidism. Okay, that's called Hashimoto's. That's the condition where you have a sudden weight gain. You have this irregular distribution of fat and some of the connective tissue. Also, you might even have a little bit of the kind of a Cushing's similar syndrome, but a lot of it is irregular distribution of body fat. And your metabolism is so slow, and all of a sudden you just can't lose weight. But these follicular cells' shape do play a role. So the cuboidal is healthy. When they start to get flattened like a squamous cell, that's also indicative of issues. But whenever they're able to be nice and full, they can produce and release a TBG. And TBG is affected by other hormones. So just be mindful of that. 70% of all the hormone in the blood is going to be your T4, and then 80% will be the T3, and then they bind to your TBG. TBG is predominantly generated by your liver. So your liver, which is affected by the sex hormones, will then indirectly affect the binding capacity of TBG4. In cases like, let's say, if you're on birth control or you're taking some kind of an estrogen pill, that can increase the amount of TBG activity, which will then bind up more, thereby reducing the free availability of TBG4. Right? So you're like, oh my God, why am I feel like I'm hypothyroidic? Well, maybe you're taking this exogenous sex hormone that is affecting your liver, which is then affecting the binding capacity of it, and therefore you need a supplement with TBG4. So oftentimes the endocrine snapshot of a patient, you got to think about multiple systems together. And in the real best case scenario, whenever I think about endocrine and just treatment options, is you got to look at all the different compounds that is affected, right? It's never going to be, oh, here's this one shot and just take it. And then hopefully the other ones will compensate for whatever's lost. Okay, over here, so for example, when you have high estrogen levels, it's going to inhibit the breakdown, and so it's going to reduce, thereby boosting up the amount of TBG levels. When you have an increase of TBG, it's going to bind more of the hormones, so the free versions are going to go down. Okay, so as a result of the panel, the total free versions are going to go down, but because you have more binding, the total amount that you have will be higher, because more of it is in the binding capacity, but you're not releasing it out. The counterpart is the testosterone does the exact opposite. Okay, so if you have testosterone therapy, or somehow you have, let's say, I guess the best case scenario would be PCOS. Okay, so when you have polycystic ovarian syndrome, in cases for females, you have a higher amount of androgen. So when you have more androgen, that means maybe you're genetically going to be more active with less of the aromatase. So you don't have less, so you're getting more testosterone, less estrogen. because of the high testosterone, it affects the liver's ability to create the TBG. TBG now is reduced, so less of it's bound. So your free version might go up and changes your metabolic activity. Okay, so it's a lot of it is indirect reactions. And then in some of the clinical scenarios, oftentimes whenever you see a patient that has a drop in TBG, that usually means there's some kind of liver failure. So hepatic failure or liver disease, cirrhotic liver, liver cancer, liver tumors, they will oftentimes accompany a drop in TBG, which will then have a slight boost in the free versions of the hormone. So you might think that's a good thing, but in reality, the total amount is reduced. Does that make sense? So oftentimes you're like, oh, hey, T3, T4 are in good range. That's great. But then the total amount that's available is reduced, and that's a problem. So whenever they do, and this is one of those small nuances, I think, in healthcare with testing that is actually the issue, is that because it costs a lot of money for the hospitals or insurance to test your blood work, but whenever you get your first initial panel, it's never enough. I don't know if you guys have this example, but every time you go in, unless you ask for, hey, let's look at the TBG or the TSH, they won't give you those panels. They'll always give you the generic, give you the insulin, the T3, T4, but that only gives you half the picture. And in the follow-up, they might say, hey, we got to look at another set of hormones, and you come back another few more weeks for another round. So every single one of those tests costs money. And that's why I think there's an issue. It's like, well, if you did a full body snapshot, you could get the whole picture right there, right then. No more of this playing around, cutting corners, reducing money, right? Because healthcare shouldn't be compromised. That's how I see it. But anyways, the increase in the T3, and this is one way to actually assess TBG levels, is by using this radioactive binding capacity of T3 synthetic resin, and you can measure how much TBG is available. And again, whenever TBG is decreased, you could almost be able to say that there's some kind of decline in your liver capacity. Same thing goes for SBG. Okay, so TBG, thyroid binding globulin, and the sex hormone binding globulin, they're basically the same story. All right, are we good on that? So SBG, TBG, same story. So think of the sex hormone and then the thyroid hormone. Now, as far as regulation goes, one of the natural ways to boost up TSH, TRH is actually through temperature. So one of the benefits in recent studies of the cold plunge and then getting an ice bath is that it's a natural way to stimulate your brain's ability to make TRH, TSH, and therefore building up more T3, T4. Not really a fun way to do it, but it works. And then over here, just remember that the tier system comes from TRH to TSH to T3, T4, and the whole point is that your body's external environment, the availability for exercise, and then the cold temperature can change the abundance of that. Okay. Over here, let's talk a little bit about diseases for the thyroid. So on the left side, we have in blue, hypothyroidism, and on the right, we have hyperthyroidism. What's, I think, important for this phase is at least knowing what are some of the outputs of these diseases. We're not going to go into some of the details, but you can see right here. So on the bottom, I have a chart. In normal conditions, when you have a healthy amount of T3, T4, it's going to go back through negative feedback, turn off TSH, the TSH should go down. If T4 is really low, then TSH should go up, right? If it's low, tier 3, then tier 2, tier 1 should go up. In the hyperthyroidism case, what do you see? So in this disease, that means you have hyperthyroid. That means the thyroid gland is overproducing T3 or T4. And then somehow the tier 2 is still telling it to make it. So in this case, TSH will be low and T4 is still really, really high. Where is the disease in? So in this second picture, so the normal, right? You guys see this one picture? This is normal. In the second picture right here, the one that we're looking at, the second one, is the disease in the brain or in the gland? If your blood panel comes out with low TSH, but high T3, T4, and then it's hyperthyroid. Is it the brain? It's the gland. It's the gland, right? So think about it. In this scenario, right, in this picture right here, the second one, the thyroid, the brain or the pituitary gland is dropping in amount of TSH. So in a healthy person, that gland should be, hey, we got enough, so it should go down. Right? It should go down and down. But in this scenario, you look at this. The T3, T4 is still going up. It's still being made, but now it's going back to the brain, but nothing is being done. So that means the issue is the thyroid gland. Exactly, right. So if first, let's say if the brain was the issue, this will be really high. So we'll draw like a dark red arrow over here. So the TSH will be super high, flooding to the butterfly gland, and TSH or T3T4 will be really low, but it's still going. That means the brain is over signaling, and then the thyroid gland is responding appropriately, but the brain is just going crazy. And then as a result of that, we have the way we can describe it as primary or secondary. So primary hyperthyroidism usually is going to be when you have this one where the pituitary gland is overproducing, just like we said. And then the secondary is going to be hypothyroidism, where it's too low. Right? So over here, we have hyper versus hypo. The general classic presentation is the blood panel, or the patient will be, patient that is 50 years old comes into the hospital, and they do a blood work. And it turns out to be that their T4 levels are too high, and then the TSH level is really low. That's a general way to remember it. So high T4, low TSH generally is hyperthyroidism case, classic case. And then whenever you have low T3, T4, but high TSH, usually hypothyroidism. The kind of the hidden one is maybe it's in the hypothalamus. Then you got to test for the TRH and then one level above. Okay, so there's a series of the hormones that you got to assess. Okay, let's pause it there real quick. We'll take a quick break. We'll come back, and then we'll finish up on a few more slides here, and I'll get into some of the questions. So what we have over here now is we were covering the thyroid gland and its ability to secrete T4. We talked a little bit about pathology. So when you had issues with hyperthyroidism, the general pattern you're going to see is T4 is elevated while TSH is low. And then hypothyroidism, you're generally going to have that flipped around. So T4 is usually lower, and then the TSH or TRH will be usually really, really high. Oh, welcome. And then morning. And then over here, we're going to go over the calcitonin PTH. So calcitonin is a hormone that's secreted by the parafollicular cells, also known as C cells inside the thyroid gland. These are the ones wedged in between the colloid follicles. And the target is mostly the bone cells. Okay, more specifically, the bone receptors for bone remodeling. And then the parathyroid hormone is the counterpart. This is the one made by the glands called the parathyroid gland on the posterior side of the gland. And its main function is to boost up availability for calcium. So you have one that can increase calcium levels by releasing it, and then calcitonin reduces it. So the term that, or the mechanism that action is called resorption. Bone breakdown through osteoclastic remodeling. Right? So bone osteoclastic is kind of like a macrophage cell. Dissolutes, secretes acid, and it melts off the bone, thereby releasing calcium. Calcium is available in the blood. Your kidneys are going to boost up the retention of calcium, and therefore you have a little bit more reabsorption. Okay, so PTH increases calcium levels through reabsorption, so increases osteoclast activity to give your body more availability for calcium ions, and then calcitonin preserves that. The application to this is during menopause, and a lot of times the best way to, and even for males. So for males, you go through andropause. Okay, so as you get older, once you get 40, 45, you decrease the amount of natural testosterone. It's going to drop. Same thing for females. The moment that you stop ovulating, then the hormones are not going to be able to have a receptor. And the mechanism of menopause is pretty straightforward. What happens is the ovaries contain these follicles. The follicles have the granulosa and the theca cells. Those are the receptors for estrogen and progesterone. So now what happens in menopause is the ovaries have gone through so much shedding and so much ovulation processes every month from the day you start puberty till 40 plus. Your ovaries are pretty much toasted at that point. It is. And then basically you have this corpus luteum all over where it's all scar tissue and no receptors. So your hormones are produced, but there's no receptors. There's no feedback. And now your body goes off in the situation where the hormones just kind of break off. Right? And that's menopause. And then over here, what happens is because of that, the thyroid hormones gets affected. The calcium receptors are also affected as well. And therefore, you have this quicker breakdown where the PTH availability is overtaking calcitonin's ability. And therefore, you're breaking down bone so much faster than forming it up that you have a higher chance of osteoporosis. So menopause linked to osteoporosis is through the hormones, through thyroid, and through PTH calcitonin interaction. Okay, so these two hormones, let me show you what it looks like. So when you zoom into the parathyroid gland, we have the two types of cells, the oxyphil cells, which play a role to the most accepted regulation is that it plays a role to intermediate the chief cells. The chief cells or the C cells is what makes the PTH hormone, and this is what stimulates the osteoclast activity, thereby boosting up calcium levels. Let me show you the image of what it looks like. So when you zoom into the PTH gland, it looks very different than the thyroid gland. Okay, you don't see the colloid, you don't see those big bubbles. You'll see some blood vessels, and then you'll see this dense pattern of cells. It's all kind of, I would say, probably more hexagonal shaped than cuboidal, but they're all little stacked together. They look almost cancerous looking because of the density of the cells and how close they are. And then around it, you have these bigger, rounder cells called the oxyphil cells. They're thought to modulate and regulate the activity of the chief cells. Okay? The chief cells are the main cells. Oxyphil cells are the cells surrounding it. Why is this important? Is because when you do a biopsy of the thyroid gland, just be mindful that it does contain the parathyroid on the posterior side. So if you're looking at the thyroid gland as a whole, everything looks like little bubbles except for the parathyroid cells. Okay, so that's important. This is on posterior side, so you got to extract it from the back. Okay, let's move on to the adrenal glands. Adrenal glands is going to be sitting on top of the kidneys, and then it has the outer cortex, inner medulla. The mnemonic or the kind of the code here is GFR MGS, right? So you could use that to make the sentence. So GFR is like go find Richard, MGS make great sandwiches, or something like that. So GFR, glomerulosa, fasciculator, reticularis, and then the M is mineral-based hormones, which is going to be aldosterone. Okay, so the mineralocorticoids, and then the G stands for cortisol, so the glucocorticoids, and the S is sex hormones. Over here, I have the GC for cortisol, mineralocorticoid, aldosterone, and the sex hormones, androgens. In any case of the tropic hormones, whenever you have too much of them, it's a disease. Okay, so let's use another example. So for cortisol, there is a condition that is when you have elevated amounts of the stress-fighting hormone. Right? So we all heard about cortisol being it's a good hormone that regulates starvation and survival. But when you have prolonged hormone of cortisol, what happens? Well, what's an output of cortisol to the body? Mineralization. Okay, good. So it's a stress regulator. Right? When your body is under physical, mental, any kind of stressor situation, cortisol spikes up to help energize your body for survival. Right? And so prolonged cortisol usually gets to a condition where it's called what? Anybody? You guys go over Cushing's and okay, yeah. Cushing's disease, when too much and then too little, is called Addison's, right? Addison's. And as a result of that, you also have redistribution of the lymphatic fluid and distribution of fats. So your metabolism changes, slows down your body's ability to manipulate sugar, go through all the citric acid cycle, etc., and also shift beta oxidation. Did you guys get a chance to go over hypoketosis, hypoglycemic issues? Okay, so when you have a drop in cortisol, what happens? When you don't have any cortisol, then your body becomes hypoglycemic. And if you were to have an impaired long enough effect on the cortisol, you might also affect your fatty acid metabolism. And so that's the worst case scenario. That means your body is depleted of any way to get energy. So your ketosis, so for ketone body production, that's when your body's starving, you tap into fatty acids. Fatty acids gets converted into this intermediate called enoyl-CoA. Enoyl-CoA becomes hydroxyacyl-CoA, and eventually becomes acetyl-CoA. The whole point is to make acetyl-CoA. That's that intermediate between the Krebs cycle to the glycolysis, right? That little intermediate phase. And then acetyl-CoA gets energy, so it makes ATP. But when you have prolonged this dropping of cortisol, it shocks your body's metabolism in both sides. Then you become a condition called hypoglycemic, hypoketotic, HH for short. So you're shooting down your ability to make sugar energy, and you're shooting down the ability to make fat conversion to energy. And then you become absolutely listless, you're super fatigued, always tiring. The issue with that is when you have this early on at an adolescent or infant, the baby or the kid or infant usually has a very low activity level. They can test that for grimness. So if you were born with a hormone defect or a reduction of the enzyme that generates cortisol, then the infant will have very low activity and low grimness, meaning when they give the baby a little prick on the feet, there's no reflex, no reaction at all. Okay, so that's a kind of a worst case scenario when it's really, really young. And then mineralocorticoids, aldosterone, this one regulates the blood pressure, and sex hormones, which we'll talk about at the end. The medulla of the adrenal gland generates the catecholamines, which is going to be your epinephrine and norepinephrine. So that's going to be the chromatin cells, another set of cells. Over here is a visual showing you the anatomy. As far as the blood flow goes, make sure you're aware that you have the abdominal aorta coming down. And then on the left and right side, we have the right phrenic artery. Left phrenic, let me use another color. So right phrenic artery, that's the main supply that branches out from the abdominal aorta. So this is the right phrenic. Left phrenic. And then we have the suprarenal arteries, which are going to then penetrate onto the top part of the adrenal gland. This is the supply. Okay, so the names pretty much can tell you where they go. So again, right phrenic to the right suprarenal, left phrenic, left suprarenal, and then on the bottom here, you'll see the one that's supplied to the middle region of the adrenal gland are going to be your middle supra, and then the right middle. Okay, so that's pretty straightforward, not too bad. But make sure you know those three sets of blood vessels: right phrenic, right suprarenal, and right middle renal. Good. Okay, so here is the anatomy cadaver. So you can see right here the adrenal gland on top. You can't really make do of the vessels because they're actually hidden in the back, but you can see just a small structure of the real one. Okay? And I also have the cadaver images to show. This is a good one. Okay, so right here you can zoom into the cortex capsule, and then in the outer layer, oftentimes you're going to see the different distribution of cells. And if you look closely, these cells are so closely linked that when there is a condition with a tumor in the cortex, it's oftentimes going to affect both hormones. Very, very rarely do you ever have adrenal tumor that's only in one layer cell. Does that make sense? Like 85, 90% of the time, the tumor is here, it grows, and it's going to impact usually 2 or 3 of these hormones. So whenever there's cortisol issues, there's probably going to be aldosterone issues. It's because the cells are so close. And then over here you can see that which layer is substantially thicker out of the 3? Fasciculator. Okay, so the glomerulosa is a very thin bed of cells. It's a very small layer. Fasciculator makes which hormone? Cortisol-based hormones. And then the reticularis is androgen. So you can see that majority of time whenever there is a tumor inside the adrenal gland, you could almost guarantee that the cortisol is affected. Their ability to regulate the sugar and to be hypoglycemic or hypoketotic, either too much or too little, it's always impacted. Okay, it's just a matter of the cells being so close, and there's no gap between the two. So whenever a tumor occurs in the adrenal gland, you could bet money that the cortisol is compromised. Okay, so that's your 3 layers of cells. Over here, just summarizing what I said. So the GFR, MGS, this is the mnemonic to use to link them together. Aldosterone, corticosterone, that's the precursor to cortisol, and the androgens will be your sex hormones. One of the impacts of the aldosterone system, because I want to give every hormone a little highlight, is the RAS system. Okay, and I know you guys went over this before, but just really quickly touching on this, is we have the renin, angiotensinogen, angiotensin aldosterone pathway, and we did say that the angiotensin 2, angiotensin 1, these are all constrictors. The whole point is to prevent any more fluid loss. You want to keep the fluid in the body. You're already at a drop in blood pressure. What can you do in your body to conserve it? And then for the reticularis, the hormone that I want to highlight is DHEA. This is called dihydroepiandrosterone. This is a precursor. This is actually a really good supplement to take to boost up natural amounts of sex hormone. And that then gets converted into androstenedione. This is the precursor to testosterone. And that goes into the famous testosterone. And then there's one reaction between testosterone and estrogen. Even though the function of these 2 hormones are night and day difference, it is one reaction apart. So this is also why it's very easy to see that in the broad population of patients and individuals, some people naturally might have an elevated amount of aromatase activity. Okay, that enzyme aromatase might be just a little bit higher elevated in this female, and therefore the female might have a better response to certain hormones and maybe more muscle density than others. Vice versa. You could also be born sexually as a male, and you have a lot higher aromatase, and therefore you're making more of the estrogen. So you become more feminine. You could also be female with less of it, then you become more male, masculine. Anybody know the condition when a female becomes extremely male with sexual characteristics, what happens? Huh? Realization. And what happens? What happens to the hormone panels? So it would shift the reactions, right? So remember, steroidogenesis starts all from cholesterol, pregnant alone, then progesterone, and then you have the 17 alpha, and then it goes on to the far right leg of sex hormones. It's going to shift the reaction across. So you're going to have more likely elevated amounts of pregnant alone and progesterone because your body is not able to convert the final form. Because you're having more of a traffic buildup in the first set of the reaction, not the final set. So let me show you a picture of that. Did you guys get a chance to go over steroidogenesis in any of the classes? This one. Well, basically this on the right. Okay, good. So perfect. So this is a snapshot. You don't need to memorize all the enzymes. I don't think that's useful at this phase, but you should be able to recognize that it all starts with the common cholesterol. Okay, cholesterol goes to pregnant alone, and then progesterone. That's the first common compound that gets made, both males and females. Then we have the 17 alpha version of those hormones. Okay, so all you got to remember is you have the 17 alpha hydroxylase. This is a limiting enzyme, and then it makes into the 17 hydroxy, pregnant alone, progesterone. And the far right leg, this is what I want you to focus on. The far right leg, you have DHEA, dihydroepiandrostenedione, and then you have androstenedione. I listed the enzymes here because in the inborn diseases, in some mutations, you will have deficiencies in certain of these hormones. And because of the hormones, you backtrack which enzyme is lacking. So some enzymatic activity might be lower, so therefore you shift it to that other side. The reactant is a little bit high. You have a blockage. So imagine you had over here traffic over here, where now the patient has really limited capacity to convert androstenedione to testosterone. Then the precursors are all going to be elevated. So usually when you're doing an enzyme assay to measure which enzymes might be defective, or nowadays you do genetic testing, but you could test for that gene. And if there's a defect in that gene, therefore the enzyme might be deficient, then you should know which reactants might be elevated. And in this case, you'll see the main part of this picture is that testosterone is one reaction apart through aromatase. This enzyme, you should know this one. So out of all the enzymes that I'm presenting to you, aromatase is something that you should definitely know. Goes from testosterone to estrogen, but it also converts androstenedione to estrone. Estrone can be interconverted back into estradiol. So there's two legs of reaction that aromatase converts. And earlier I was saying that you could be a male born with a little bit more aromatase activity. Another application is tumors. So breast cancer, ovarian cancer, and testicular cancer, oftentimes you will regulate aromatase. You would want to have an aromatase inhibitor because that means you either have too much of that hormone already, so you block it, or you have too little. Okay? And then over here on the bottom, I show you the three versions of the estrogen hormone. So we have estradiol, beta estradiol, E2. Estrone is E1, E3. The only one that's relevant to sexual characteristics for females is E2, beta estradiol. All right, so that's the hormone. So let me go back a few slides because we're just jumping ahead because it's related. So earlier I was saying that you have the reticularis that's used to make DHEA, and that's where that comes from. We're going to skip the pancreas because we already spent some time on pancreas, so that's something that's not too important right now. So the last part of today's talk on the hormones, we'll zoom in just onto FSH and LH. Okay, so follicle stimulating hormone and luteinizing hormone. I'm going to use the female as the main topic because the ovarian cycle and the ovaries are a little bit more complex than the male counterpart. When we go over the reproductive structures next week, we'll talk about the external genitalia and then the scrotum. We'll talk a little bit more about the males next week. Right? But for today, let's go on the female. So this is the snapshot. This is how the interplay works for the sex hormones. It's very complex. If you look at the picture on the right, it's like, where do I start? Right? Like, what am I looking at? So a few things I want to point out first is the positive sign and negative sign indicates there's increasing activity via the positive sign. Negative sign means it slows it down. The hypothalamus utilizes GnRH, gonadotropin releasing hormone, to target the pituitary's gonadotropes to then release LH, FSH. Can anybody tell me which hormone in this picture is the regulator for FSH? There's one hormone we haven't talked about today. It's on the picture. Which is the only, and it only affects the FSH hormone, not LH. Inhibin. Okay, inhibin is a natural antagonistic hormone that turns off FSH, but not LH. So when you have enough sex cells, so let's say you're going through spermatogenesis, and again for males, anybody know how long it takes for you to regenerate your sperm cells to kind of get a full recovery? Probably a couple of days to be safe, a couple of days. But usually when you have like a 5-6 days ejaculation, if you don't ejaculate, the sperm cell gets disintegrated. It breaks down and gets recycled. Okay, whereas for females, how many egg cells do you release every month? One. Okay, so that regulation is based on inhibin. There are two versions of inhibin. There's inhibin A and inhibin B. Inhibin A plays a role in the beginning of the phase to limit only one egg cell. So I would say the disproportionate and the unfair nature of life is that for the female cycle, one egg cell, right? You have basically going through oogenesis, you have 4 premature oogonia, but only one cell out of the 4 survives. Whereas in the male counterpart, all 4 cells, the premature sperm cell, become 4 sperm. And so that limiting control is based on inhibin. Inhibin regulates which follicle gets to grow and develop, and that's random. So whichever follicle you choose that month is inhibin regulated, whichever receptor gets most of the signal. And then what happens is the one that gets to grow gets the least amount of suppression. So what happens is it's suppressing all the other follicles, and the biggest one gets the least amount of suppression. So therefore, that big one eventually is going to ovulate. So during that magical time in the month, during day 14, usually the midpoint of a cycle, the female ovaries will then release their eggs. Okay? All right, and then over here on the bottom, you can see that the female cycle, we have a theca cell. This is the receptor for LH. For the female FSH, it's granulosa cell. Okay? On the bottom, it's going to change your gonadal tract. And then the granulosa cell also plays a role to both release progesterone. So progesterone is what is released on both sides. As you hit menopause and you lose the ovary and you lose the theca cells, granulosa cells, then you have the brain still signaling, but nothing to respond. That's menopause. Okay, so in a short form way to think about what happens is one of the best ways to look at it is now you need to be able to replenish the estrogen in the bloodstream to maintain that wellness and feeling pretty good, feeling happy, maybe your mood, maybe feeling like a princess, and then having the progesterone availability to keep your body's normal 20-year of exposure to this hormone in the same amount. So over here, let's take a look at what this hormone does. Okay, so let's take a look at the first one, GnRH. The first hormone, this is the tier 1 or tier 2? Tier 1. Tier 1, okay? LH, FSH is tier 2, and then the sex hormones, the progesterone, estrogen is tier 3. So tier 1, this is going to be made by the arcuate nucleus and also parts of the preoptic area in the hypothalamus. What I want to highlight here is that this hormone is released in a pulsatile manner. Every hour or so, you have a slow release. What's very fascinating about hormones is how they're released. Okay, some hormones are just elevated during sleep time, like growth hormone. Some hormones, like estrogen, testosterone, they're elevated naturally during the mornings, and they decline during the day. Anybody have an idea when cortisol spikes? When's the window of cortisol in the body? Usually when you're starving or fasted, right? But also towards the evening. As you're getting ready to sleep, it kind of spikes up a little bit. Calms you down, gives you a chance to kind of feel energetic to recover. But when you have too much of it, then it's an issue. And then over here, what happens is there's an interplay between adrenaline and also dopamine. So during sexual arousal, and let's say you're engaging in intercourse, when you have adrenaline and your body's amped up, it is going to positively boost up the ability to release GnRH, whereas dopamine and anything that suppresses and calms you down might reduce it. And the other one I said briefly was something called kisspeptin. Right? That was the newer kissing peptide that actually triggers GnRH directly. So over here, you'll see that when your brain releases the GnRH in slower, pulsatile manners, it favors FSH, and when it's going in a more rapid pace, it favors LH. So that's how you discriminate, even though both of them get released. Okay, and then inhibin is only going to target which one? FSH. Okay, so that's important. So that means LH is still by itself. Now the second tier hormone is going to be a luteinizing hormone, FSH. These two cells target the theca cells. They also target the granulosa cells. Notice that I also listed that the theca cells only have receptors for LH, whereas granulosa cells have it for both. So technically, I would probably say these are considered synergistic hormones. When you have both of them, the effect is a lot greater. Okay, and then this is also when you think about, let's say, if you're going through fertility and you're trying to induce the ovulation of the egg, you want the egg to mature faster, you could give them a shot of the FSH-LH combination, the trigger shot. They call it a trigger shot. Basically, when your egg is not developing, they want the egg to develop faster to time it. You can get an injection inside the subcutaneous area, small syringe, but it's a pure LH, FSH. It's really costly. These pure hormones are super costly. If you don't know, just think about the price of insulin. Right? All these other hormones are very similar. It utilizes a GPCR system, so it uses PKA. So if you don't know what this is the activation of the adenocyclase to take ATP, convert that to cyclic AMP. Cyclic AMP then cascades down, and then downstream is going to affect the cell. That is going to be LH-FSH. Then the counterpart here is you have the inhibin. This is the one that suppresses FSH, turned off. There is a family of neuromodulating compounds called activins that do play a role to promote it. So earlier what I was saying is kisspeptin, adrenaline, combination of these hormones might enable more of it. Right? And that's why when you're thinking about certain kinds of, I think nowadays there's a lot of products out there, supplements that they claim to be aphrodisiacs that can help you engage, right? Get you kind of aroused or turned on, is because there are these potentially natural occurring herbs that might have similar modulating structures, very similar to how caffeine and theophylline are similar structures, right? In teas, it helps you bind adenosine, so both of them might have some sort of a wakefulness activity to your brain. And then we also have another compound that has been, these are all neuropeptides, so neuropeptide called follistatin. This is a binding protein that has the ability to help modulate the ability for activins to work. So when you take away the activins, then what happens to the FSH production? It's going to go down. Right? If activins increase it, and you have a regulator of the activin, then that can change the amount of being made. So let me show you that there is a negative feedback that does occur. And the main one that I wanted to highlight here is that when you are taking drugs, when you're on painkillers like opioids, oxycontins, those opioid-based signals actually will decrease GnRH, which will then reduce libido. So opioids, anything that's GABA-related, inhibiting of the brain, benzodiazepines, antidepressants, those ones are all going to favor the triggering of depression of the brain, thereby reducing GnRH. Whereas kisspeptin, adrenaline, those ones will do the exact opposite. Okay, but you also don't want to have too much, which will then boost cortisol and stress levels. So there's a fine amount where it's not just a kind of a one-size-fits-all thing. You don't just take this one drug and just amp it up to the highest. Right? There's a very fine interplay. So over here, I went over this briefly already. Just make sure you're aware that there is an enzyme called aromatase that converts testosterone to estrogen. It also converts androstenedione to E1, and then E1 can become E2. So oftentimes in patients with PCOS, there is a change to the aromatase activity. So for females that have PCOS, do they tend to have less aromatase or more aromatase? Less. That means their conversion to the sex hormone for the female counterpart, the estrogens, are not as available. So they're trapped. They're going to boost up more androstenedione and testosterone, thereby having more of the male characteristics. Maybe a little bit more body hair. They might have a little bit more muscular density, bigger bones. I mean, it might be beneficial for certain sports, but you see the spectrum of enzymatic activity. Oftentimes, the diversity of humans is because our expression of the enzymes are not all the same. It's based on your environment, based on your diet, based on your genetics. Those are all going to interplay the enzymatic activity. Okay, so let's take a look at how the cycle works. And this is where things get really fun. But before I go into cycles, last but not the least is estradiol is actually very, very highly regulated. So over here on the right side, you have the two pictures of the two receptors for the female, theca cells and granulosa. And if you're looking at where they're found, these are the cells that surround the egg. Okay, so each of the egg cell that you guys just mentioned that ruptures every once in a month, they ovulate out. There's a ring of cells called the corona radiata. That's like the crown cell that protects the integrity of the egg cell. The egg cell is the largest single cell of the human body. It is important because it contains all the DNA and it's going to give rise to your embryo and the infant. And the outer surrounding is a bed of cells that grow. Those cells are your T cells or theca cells and the granulosa cells. Notice here on the theca cells, you have the receptor for LH. And then on the granulosa cells, you also have the receptors for LH. So they're the same. And right here, they're the same stuff. The AC just stands for cyclic AMP. But on the granulosa cell, you also have the receptor for the FSH. Both systems uses CAMP. So increasing CAMP will boost up the ability for you to activate aromatase and therefore make more antigens. Looking at the picture, which one of the cells can actually make estrogen? Granulosa. So in the theca cells, it actually does not have which enzyme? Aromatase. Perfect. So then make sure you know that. In the theca cells, you do not have aromatase. It's only found in the granulosa cells. When you hit menopause or if you have ovarian cancer, you don't get to choose what cells are damaged. In some cases, you might just compromise all the granulosa cells, and therefore you're having a lot of androgen. You're like, oh, why does this patient have so much male hormones when they have ovarian cancer? It's because the granulosa cells are damaged, so they don't have the enzyme activity to convert the androgens to estrogen. Okay, so this is important. This is a detail difference. And then over here, you'll see that the function of your theca cells is to produce the androgens that will then penetrate into the granulosa cell, and the granulosa cell takes a final action to react to estrogen. Okay, are we good on that? So that's a small detail that people will miss. Okay, so now the last part of the story is going to be on the cycle. So I just want you to remember that for the males, okay, if you were to draw the male line, it will be like this. It'll be flat, and it'll be flat, okay? It really doesn't change too much. Unless you're taking certain drugs or unless you're changing your dietary habit, you're cutting down, you're depleting fats, no omegas, no fatty compounds, no cholesterol, or if you're taking some TRT, then it will change. But normally it's like flat. It's literally flat, right? You just cruise along, we're good. Every day is a good day. For the female cycle, I want you to take a look at the picture on the right. There's two graphs. The first graph is FSH-LH. The bottom graph is estrogen-progesterone. Look at estrogen-progesterone. So let me just trace a line for you, the dotted line. Day 0, so by the way, guys, on the bottom x-axis, can you guys all see the graph? I'll zoom in a little bit, maybe some help. So right here, the bottom lines right here, all these little tallies are going to be days. So day 0 all the way to day 28. The standard for a female cycle, in case you don't know, or maybe you're so reliant nowadays on your apps, and it's great that we have apps now, right? Imagine back 10 years ago when we didn't have apps. You would have to put a diary. You would have to put a calendar. Oh, this is when I have my menses, and this is my last day of my period, and this is when I do it. Now it's an app. You just log it in, you're good. So day 0, and then this is day 28. Standard 28-day cycle. If you're healthy, sleeping pretty good, maintaining good nutrition, staying hydrated. Notice over here in the beginning of the first 4 or 5 days, right here shown in the kind of dark color, this is when you're recovering from your previous cycle's menstruation. And menses is when you're discharging. The endometrium, it's shutting off. And we'll go over all that next week, the uterus and the anatomy. But you're shutting it off, it's breaking, it's bleeding off. Which hormone do you see is increasing in the first few days of the cycle? FSH. FSH. Okay, and why is FSH getting ready to rise? Well, you just finished ovulating last month. You got to pick one of the egg cells to mature. All right, so this first few days of the month is important because you're trying to figure out which of these eggs do you want to mature. Okay, so you pick one. FSH stimulates the follicle, so it begins to isolate one cell to begin to grow. Now, right here, you'll see that the LH, the dark line, starts to slowly increase as well, right? It's not tremendous, but starts to peak out as well because it synergizes with FSH. They're both stimulated by GnRH. Eventually, you hit day 14. This is about the midpoint of the month. Which hormones elevate? Which ones begin to peak out like crazy? LH. They call it the LH surge. That's number one. The black line right here peaks to 3 times this amount, close to about 40 plus milli international units per milliliter. And this is going to be the one that actually triggers the ovulation event. So LH, main role for the females is to rupture the egg follicle so that the ovum can drop out into the fallopian tubes. Masking it is going to be the highlight of the inhibin and FSH. They both rise a little bit. Guys, why do you think inhibin also rises? Why is the dotted line rising? What's the function of inhibin? Think about it. We just talked about it. What does inhibin do for the female's hormone? Which one does it inhibit? Inhibin inhibits something, right? Which one? FSH, right? So what's the function of FSH? To mature that one egg, right? So if you already had that one egg picked out and you're good, you found the egg, right? That egg is already mature and you're rupturing it. Do you need more eggs to rupture? No. So that's also why inhibin rises. It's limiting the ability for FSH to mature any other eggs. So you're ensuring you have only one egg releasing during the month. Okay? That's why you see the black dotted line also increasing. All right, so let me just zoom out one more time. So if you, again, let me clear the ink. You can see right here that the inhibin is also increasing right there, right? It's clearly going up. And then now it drops down after the ovulation event. And then the good part is the later 14 days of the female cycle is all pretty flat. Now the bottom here, you can see right here, the bottom dotted line, this is the estrogen, estradiol, raises up from close to maybe 50, 40 picograms per milliliter all the way to over 400 right before ovulation. So it does peak out right before ovulation day. And then notice that it declines. And then the later part, when, let's say, the egg is in the fallopian tube, there's that window of opportunity. So right after ovulation, this day plus 1, 2, 3, these 3, 4 days right after ovulation is the ideal time to have intercourse to get fertile. Because the egg is available, and as long as sperm can last within a few days, it might penetrate the egg. Yeah, go for it. It could be 2 eggs, yeah, 2 eggs being released at one time. So you have the right fallopian tube, the left fallopian tube, they both drop in, and then the sperm hit at the same time. Yeah, really good, yeah, exactly. And so some cases you might have a female that just happens to mature more eggs. But the whole point is that there is this, the way their body optimizes that you only want 1 egg per month, right? You want to give that opportunity. And we've been evolved as animals to have that window. So starting from puberty, when you have your first menses, the egg begins to release. When you look at fertility treatment, which is really fascinating nowadays, and we're so well versed with the hormones, you're intensively, so if you're doing what they call IVF, we're retrieving the eggs, what they do is they give you booster shots to suppress all your hormones all at once, so everything is flatlined. They then give you the estrogen and FSH in crazy amount of dosages that it triggers multiple eggs to mature. So when you go in with a little syringe to extract the egg, you could take out 10 to 15 to 20 eggs that are ruptured. And then they will take those eggs, take a few sperms, put it together, and create the baby in the petri dish, right? So the science is really cool because once you understand the hormones, you can then trigger your body to respond in a way. If there was a fountain of youth, if there was a drug that could be used to become the chemical you eat to reverse aging, I'll bet money it's on hormones. The closest thing that at least I've known in terms of signals and chemicals in the body is hormones. That's the only thing that you can target in the body where there's a receptor, and you give it the body, it directly responds. Right? Okay. And then over here, guys, on the bottom, just showing you a comparison of what happens to the cell. So this is a nice little visual. So if you look on the bottom right, you can see very clearly that the primordial follicle is a smaller, tiny little follicle with the egg, becomes the primary secondary, and then becomes the egg cell that's ruptured out. And this remaining phase right here is called the corpus luteum. Once it regresses, it becomes scar tissue that maintains the progesterone. And the final form, guys, right here on the far right, this is called the corpus albicans. That's the scar tissue. So eventually, when you hit menopause, your ovaries are literally just scar tissue all over. Okay? It doesn't have receptors, and so the issue is now you feel this change in your body temperature, your metabolism, your energy levels, because there is no receptors. And then no receptors means there's no sex hormones. Even though it sounds simple, but the amount of it is not as simple as just taking a shot every day. You have to cycle it maybe every few days. There's a different release. And a very good endocrinologist would be able to give you a plan to tell you literally day by day or week by week what flow of hormone you should do to stay that same feeling. It's hard, but it's pretty fun. I mean, if you think about it, just look at, and the best way to do this is if you're in a pretty healthy state right now, get a blood work done. Look at what your current blood work is so that later in life, when you are in your 40s and 50s, you can mimic that panel and what was good for you when you were in your 20s. Does that make any sense? That's what I would do. I think that's important. Now that I'm in my mid-30s, I track my hormones every year. I've been tracking for 4 years, and I just like look at it like a graph. So I know one day when I lose the hormone capacity, I say, hey, these are the hormones I need to stay that same feeling when I was in 25 or 35. Yeah. Cool. All right, guys. So that is the quick snapshot. I have listed over here in the slide the days and exactly what happens. I don't expect you to know all the details. It's not a big deal here. I did want to show you one more slide. This is see what hormones are going up and down.